and he oversees the largest local government-based health and social service networks as the Deputy Chief Administrative Officer and Director of Health and Human Service Agencies for the County of San Diego and its 3 million citizens, 3.1 million citizens. If I'm not mistaken, about 1/3 of those citizens touch human services during the course of a year. He has a budget of over $2 billion, has a workforce of over 5,600 employees and 800 contractors. What I would say, I've had the pleasure of knowing Nick for a few years, and one descriptor is peripatetic. The man is everywhere, but he learns from all of those engagements. He teaches from all those engagements, and we have benefited from our friendship and interchange over the last couple of years. Nick, welcome to the Commonwealth.
Dr. Secretary Hazel is too kind. I've learned more from him and his phenomenal leadership, and all of you. I'm honored to be here and share a little bit about San Diego. And somebody may be thinking, what's 3,000 miles away have in common with Virginia? Much of what we had meetings yesterday and listening to the sessions this morning, we have a lot in common. And we are really in a time of this dynamic change for state and local health service delivery. And a key part of that dynamic is all these multiple determinants that are influencing health of people and their communities. And what we're trying to do is really figure out how do we better manage those determinants, how do we better resource those determinants to have more effective, efficient government and communities. I was asked to talk about two of those key determinants, health and safety. And before I do, just a little bit about San Diego. I know most of you think about it as the opening scene of Three's Company when they were frolicking through the San Diego Zoo, because that's what I thought about it when I was in New York City. But it is a large community, quite diverse, with Indian sovereign nations to 3,000 agricultural farms with desert towns. But I guess the similarities we have is also the large number of military and veterans. 1.1 of our 3.1 million are military veterans and their families. And we are a military veterans town and community, very much like here in the Commonwealth. We also are very diverse in terms of languages and cultures, in terms of the type of people that are moving and living in San Diego. And our structure, being that it's county government, not state, we have 5 elected officials who are known as supervisors, as well as an elected district attorney and sheriff. And we have these, what we call business groups, public safety, that has all law enforcement, the finance group, and of course the group I have of the 5 is Health and Human Services. And why we were created was because of this. And why we're in this conference is because of this. This illustration captures the essence of everyday living, that many factors influence families, vulnerable adults that have to navigate through this. And I know we all live in this sandbox and have to navigate it ourselves, so we know firsthand. But now do this for people who come into our safety net for whatever reason, array of reasons, and this complexity is what we're trying to navigate, and it's only growing in its complexity. And so data and the analytics is really a tool to help us navigate this type of complexity. But so is structure. And for us, in 1998, and I was there when we created our Integrated Health and Human Service Agency, we took all these different departments that were touching many of those services in the prior slide, and we created. And slapsticking them together doesn't necessarily mean you're going to have the type of functionality you want to achieve. But it was the journey. And the journey for us was really looking at the whole continuum of care. We serve over 1 million clients across all our programs. That's almost 1 out of 3 San Diegans that are touched, as Secretary Hazel mentioned, Health and Human Services. And you could see we're a large organization, We do not have a county hospital. That's important for those that are in the health world. We contract with our partners. And I'll talk about this concept of co-opetition that is very real and something that we have to make work in San Diego. But something that we do have in common is that we have contracted out our IT, our entire IT department, as you have here, and we are big fans of public-private partnership where it makes sense with community. We contract with 1,000 nonprofit organizations across the county. And with that, our emphasis right from the start being that the TANF reform was an impetus for creating the no wrong doors of helping families achieve self-sufficiency. And here we now go, the bookend on health reform. Then on all of these type of major reforms, they're large population-based. And for us, one major challenge on the health side was this issue which the governor so eloquently described, these three behaviors. And let me explain. In 2008, we watched, as all of you, the senators debating for the presidential campaign, and we knew what was going to happen was some type of reform at the federal level. We thought it was going to be coverage and payment reform, which in fact it did. But it was silent on service delivery reform. And that's where states and local jurisdictions are really living in. And so we started, and we took a hard look in the mirror to say, well, what are the things that are most impacting us? And the Irish philosopher Bono from U2 said, it's the simplest things that have the greatest impact. And it's connecting with people, and those simple things was the lack of exercise, poor diet, and smoking. You see, this 3-4-50 is a World Health Organization definition. The one, and I would not correct the governor, but 3-4-50, which is actually, when we started this in 2010, was 3-for-57, to be exact. This 3-for-50, or greater than 3-for-50, is also true here in the Commonwealth. It's true in every community in this country, including places like now Mexico and Canada. So these simple behaviors, and I know many of you are chagrining right now looking at that cheesecake as I'm having this conversation. So I'll go through this slide quick. All in moderation is what Secretary Hazel tells me. But these three behaviors are killing us. 4 chronic diseases. In rank order in San Diego, it used to be heart disease. I'll talk about how we have effectuated that to reduce that as the second leading cause of death, as including stroke, now the third leading cause of death, because of our interventions as a population. But it's cancers, it's heart disease, it's diabetes, it's respiratory illnesses like asthma and chronic obstructive pulmonary disease. They lead to over 50% of all deaths. Here's the catch. 70 to 75% of those 4 chronic diseases are preventable. They're environment-based, they're behavior-based. Only 25% are genetic. That gives hope that we can effectuate change, because we also looked at the economic impact. And we wanted to know for taxpayers, this is where the data, the power of data, really comes into play to move a major population issue like this. We said, what does it cost taxpayers? And in 2007, we did this economic study. We refreshed it actually in 2010. But it was about $5 billion in direct medical care expenditures on those 4 chronic diseases that we spent in San Diego. We did not capture the costs to loss of productivity to employers. So this number is way north of $5 billion. Tom Frieden and CDC did a study similar in 2012, the Centers for Disease Control and Prevention. They estimated $1.2 trillion is what we spent as a nation on those 4 chronic diseases. $1.2 trillion and growing. There's the economic imperative where we can make a difference in our national deficit on this alone. Why this was really important was that was our battle cry. We came into realizing we're going to have to fix ourselves, and coverage reform is great. We need that. And we've expanded Medicaid in San Diego significantly. But it was beyond just access to health care coverage. It was changing the rest of the system. And so we came up with this pretty audacious approach, a 10-year commitment, not a sprint, but a marathon, knowing it's going to be passed on from Bhutan to others, but we call it Live Well San Diego. And it's predicated on not only building better health, but living safely and thriving. When I worked in the inner city of Newark, New Jersey, and when people were fearful of walking the streets, they weren't exercising or going to take their kids to their immunization clinic. They were fearing for their safety. So in the presence of violence, you can't achieve health. And that's why it's so important what you're doing here and looking at the interplay of what you do in public safety and what you do in health and human services, because they're vitally, and education, they're all interconnected. And so we wanted to look at how do we really make the difference in the region, countywide, intra-departmental, intersectorial, in every sector of the community. And here's the kick, with no new money. That's a kick. I was kicked many times for saying that too. Yes, we're blessed. Everyone wants more resources. We have gaps. We have wishes and needs. But the idea here was really taking Don Berwick's principle, and that is, how do we optimize our existing resources in a way that improves outcomes? And I've been to many communities, and they've said, no, we got gaps, we got gaps. And I say, take a hard look in the mirror. Did you use or did you think of X, Y, and Z? Because that's where we were in San Diego. And they weren't thinking about using the resources in a way. You are an amazing group of resources in this room. How you're optimizing one another fully to improve the outcomes for the Commonwealth, you only can answer that. But I think it starts there before we start asking for more. And that really was then our journey. And we wanted this single vision with a very comprehensive approach. And what's important is we built it by data, and we're data-driven by it. It was really important for our electeds to answer the simple question every year in public session, so what? What have you done? How have you impacted spending not $2 billion, but the county budget of all departments is $5 billion. Because every department is part of this. It's not Nick's plan, it's the San Diego plan. And we intentionally did that. We intentionally developed the architecture on this, that it was everyone's involvement. And so this one vision, these three components of health, safety, and thriving, then we said had to have shared strategies. That really, when you're talking about serving our veterans or dealing with safety in communities or serving special education or giving immunization to children, it's about a service delivery system. Not healthcare, so it's a service delivery system. It's about the issue of positive choices. We don't believe in big government in San Diego. I think you share that. We're not going to take away your Chunky Monkey ice cream or your cream cheese cake there, chocolate cake. By the way, chocolate's good for you. That's what Dr. Hazel told me. But we believe, though, as government, as a partner, and as helping people who come, for example, into our food assistance programs, TANF, and coming into food assistance, giving them the health education, so that when they leave our system and achieve self-sufficiency, they're healthier than when they came in. Not necessarily unhealthy because they had access to food, not making the best possible choices. That's what I mean about positive choices. Policy and environmental changes. It's overused a lot, health in all policies, but we're serious about that. Health and safety, we say, in all policies. The braided approach. How are we making a difference? And I'll illustrate that in a moment. And then, very importantly, changing the culture from within. I didn't ask this to Secretary Hazel and the other secretaries, but if we're asking others, large employers, Commonwealth and state government's a large employer. If you're asking the other large employers to take accountability for their health, are you leading by example? How is your own wellness happening? And we're not doing that fairly well as the fourth largest employer in San Diego, but we are now, making wellness a priority for our employees, trying to achieve a return on investment, but more importantly, building the culture with our 17,000 county employees and our dependents, some 30,000 family, that health matters, and we mean that for our own employees and their safety. So what does it mean then when we talk about, sorry, let me go back. Evaluation was a real key. And I'm going to have a website link. I don't have the time. But we drilled down. We wanted 5 areas of influence. You could see it's about health, about community, social living. But in each of these 5 areas of influence, we wanted to keep it simple. We developed indicators, metrics. And some of these are quite audacious, like improving life expectancy. But we said, that's audacious to begin with. But the second one is even a bigger one. Living longer and being grumpy is not really worth it. Right? We said we want people to live longer and we want a more quality life. That's audacious. But if other developed nations can do it, why can't we? So we are driven down in all these indicators and we measure. And we are transparent with the public, saying government cannot do this alone. Government shall not do this alone, but we'll do this together. And that is mobilizing much in the community. And I'll tell you, it was very big for our electeds to put themselves out there. Term limits, they're not going to be here. They want to get something done. And you talk about expanding three years of life over how many decades? But it's important. So what do we mean by building better health? It is these things, access to quality care, all the things we know. But let me tell you how it illustrates. We have the second largest elementary school district in California, Chula Vista. Today has 29,000 school-age kids in one school district in the southern part of San Diego. In 2010, they had a dilemma. 40% of the school, and at that time they had 25,000 kids, had an abnormal body mass index. It's called BMI. They were overweight. 40% of the school. Shocking. Kids were missing class. They were losing their ADA funding. They approached us and said, we know you're doing this live well thing. Is there a way you can work with us and help us? We've tried other things. And we said the only condition is that we partner with you. We're not going to dictate school policy. You know to know your own culture. But it's going to be important that the school board, the superintendent, the principals, the teachers, the PTAs, the parents, and the kids have to be aligned. And you have to do a BMI for all kids. They were able to get almost 24,000 parents to agree to do a very controversial thing, which is giving consent to take your height and weight as an aggregate measure. We then did the things like all schools do. We looked at their school policy, their food, their exercise, and so forth. But we also worked simultaneously in the community, working with surrounding businesses and neighborhoods. Cleaning up parks. This is where health meets safety. Because Harborside Park was unsafe. They weren't using it. And we went to Chula Vista, the school, and said, we need your help. We got to clean up this park. There's a health imperative here. There's an economic imperative here. And they did. 2 years later, 2010, we showed a 3.2% reduction in the abnormal BMI. As Superintendent Escobedo said, that was 800 kids. He could fill an entire school that now are in normal weight. They are such on fire with this. They did a toolkit. And we said, could you help us bring this now to the other 41 school districts? And I'm really proud to say 2 weeks ago, all of them have signed on. 650,000 school-age kids is what we're on to now. And 3.2% is pretty colossal for 2 years for population-based, but we want more. And we're looking at now a population-based approach. This wasn't government dictating. This was government helping, enabling. Safety. Many initiatives on safety, from disaster resiliency to neighborhoods are safe, residents are protected. We are the second largest Chaldean placement, refugee placement after Detroit and San Diego, Iraqis. And we started having a situation in El Cajon where our fire and emergency departments were literally ranked 5th in the nation, busiest per capita, like after New York City and LA and Miami. And this is El Cajon, a little city kind of. And the reason for that is that the Chaldean community coming in didn't know how to use and access the healthcare system. And so they thought when they had a medical question or so, or they had a problem, is to call someone to come over. They dialed 911. That was not good. we used an evidence-based approach, Project Shine, to come in and begin the education process, working with the community leaders, the Chaldean community leaders, working with the schools to help educate the kids, working with those that were in the ESL classes. And I'm proud to say over an 18-month period, we've reduced the 211 to the normal, 911 to the normal call volume. Saving lives, saving money is an example of what we do in terms of thinking of living safely. So what links both these are, and what we've been talking much about this morning, it's about person-centered. It's about systems of care. Notice I didn't say systems of healthcare, systems of care, of service. And I'm going to give an example of care coordination. And then this concept of accountable communities for health. And I think this resonates really well in the Commonwealth, because it does in San Diego. And for us, the person-centered is very easy said, hard to do. How do we move from the fidelity of our professions? Because if I go here and people will say, it was mentioned, we have a neurologist, my good friend John O'Bainin, we have an orthopedist, we have all fidelities to various professions, social workers, nurses. But how do you move fidelity from the profession to fidelity to the cause? How do you move from program-centered to this concept of person-centered? And that means a lot of interest-based negotiation and give and take. But it means, and this was meetings we had yesterday with many of the departments, of finding mutual interests and where we can begin to look at that person in the center and not with the badges and the egos that sometimes get in the way. And we're doing that inside county government with our departments, but we're also doing this in the community. And this is quite challenging to do, but it's important work to do. Because we couldn't get to the Chula Vista Elementary School if we weren't having this type of conversation, saying, let's put the best interest of the child in the middle. How do we do this? And we brought in the business community, the schools, public health, the educators, non-based organizations, and the faith community with our existing resources. I really appreciate Dr. Cohen and Dennis and how he's talking about data across the lifespan, because we agree. And for us, what struck me in the conversation was, well, yeah, it's an integrated data system, but maybe even a simple question for me was, what programs do we currently have and how are they aligned? Just asking, what do we have? And I asked first the question of how many kids are we serving, and I got blank stares. And in our behavioral health system or child welfare system, it always took time to get back. But then I took it a notch further and said, I don't want to know also the kids we're serving. What are the programs we're serving? And how are they integrated? Because we have kids that come in our system and stay in our system. We have people that come in and out different parts of our time of our system. But we wanted to understand what were those drivers. And we were trying to look at crossover youth at the time, kids that were both in child welfare and probation. And that opened our eyes on how other programs they were in, and then as they were becoming young adults, what other programs they were accessed. I can tell you, when we had this chart and sit down, and Dr. Julie Howell's here, Senior Policy Health Advisors, there were a tremendous amount of ahas. This is potent simplicity. I don't get it. I mean, it seems to me we should all, at least in San Diego, we should have had this down, and we didn't. We didn't. Maybe there should be a symposium where we all take this white space here and we write this out. We wire out how all these programs tie together and where they don't and where the gaps are. And that's equally important for us. And you'll see in terms of the underpinnings of how technology has to help us with this in data. So I want to give you two quick examples of how we've used this concept of care coordination. One is on the health side. And the health coordination for those that are coming to hospitals, CMMI did a grant that we got for 21,000 Medicare fee-for-service clients for 11 hospitals. And they were struggling because they had a large percent of these patients that were recycling, being readmitted. Now there's new penalties because of the Affordable Care Act. And so we said, why don't we align what we have in the community, our area agency on aging, our folks that in the community work with this population. And here's the kick. In a matter of 2 years, we reduced the readmission rate for this population of these 21,000 subset of them with heart disease, chronic conditions, multisymptomatic. They were about almost 40%. For those that fully completed the program, under 12%. In the words of Donald Ryan, a 74-year-old, as an example of a client, a veteran, he said what this helped achieve was his wish, to sleep more in his own bed than a hospital bed. That's why we did this. Improving the life of the Donald Ryans of the world. The cost savings are immense, and that story is being told now. We then said, if we could do this for healthcare, why not for the other population? Who else do we have that's multi-symptomatic, has issues of bed stays, and costing taxpayer a lot of money? Oh, our inmates. So we developed this community corrections partnership, which brought in everyone with a gun except me. Even our judge carries and packs. And you could see who's on this group here. And it was pretty novel because the idea was, how do we do a better job of the 60–70% recidivism rate that the state was doing with state jails? We could only get better. And we were looking at it at our county jails, looking at how do we really align services in a way that get people on a path. For me, it was on a path of recovery. So they weren't coming back in the jails. They were being good fathers or mothers, taking care of their families, being productive, good members of society. That was my aim. For the others, they just wanted to get smaller jail beds, not more. Because we knew we couldn't arrest our way out of the problem. We couldn't afford it. We had overcrowding